Thanks a lot. Thanks to the board, Dennis, that you invited me again, and that you go abroad and look into other applications other than breast, which I specifically would like to encourage you, because it's a very interesting development of that low energy irradiation device. It came from the brain. It actually has its odd shape. It's an accelerator with a needle. And I don't know if you've ever thought about it, but that needle went into a brain before Zeiss bought the machine. And they irradiated, they mounted it on a stereotactic frame and irradiated brain metastasis with it. Very successful. There's a lot of Harvard data that was very successfully irradiating, interstitially irradiating brain tumors metastasis. Then Zeiss bought it and then developed it sort of into a breast tool, and now recently into IoT suite. So basically, for the business cases, mostly it's involving also rectal, it's involving head and neck. Bill, you're going to talk about that. There's a new GYN application, endovaginal brachy. You can still do that with stepping source. We were in 2011, 2012, we're thinking about, well, there's so much going on in breasts, in non-brain where they came from, but what about the idea to put that back to the brain? Because we have a big issue in the brain. Mostly all brain tumors will recur at the site where you do surgery. Almost every tumor comes back at the site, and the worst of them are the glioblastoma, the sort of the most aggressive primary brain tumors. And that was the indication where we said, well, there's nothing going on. We treat patients for more than now 13 years. We treat them the same with radiotherapy, with chemotherapy, and these patients still die after bit more than a year, and these tumors come back after 6 to 7 months in the cavity. It's so frustrating. You operate, you do radiochemo to the cavities where the action is, and these tumors come back right there in your face. And we thought about, let's go back and put that intrabeam in the cavity where these tumors come back, because I'm going to go into detail. It has a very nice, there's a very nice prerequisite in terms of biology and also of physics in that situation. For those that are not all into brain tumors, glioblastoma is the most devastating brain tumor you can get. If you have this tumor, probably you're above the age of 65 or even older, and you're treated with a protocol that has not been changed for more than a decade. The progression-free survival, something that you from the breast side are used to have double-digit numbers. We're happy if we see one patient with a double-digit PFS. We have about 6 to 7 months, and then these tumors come back, and then the life expectancy is another 6 months. And that's what I was talking about. The pattern of failure is basically this tumor basically always comes back in the cavity, and that's simply because you cannot resect it. You don't know when functional brain starts and when the tumor ends, so to say. You can use some enhanced technologies, you can use some substances that may enrich in tumors, but basically you don't get that tumor out. So this is what you're going to have. Locally, these tumors come back in almost every case. Isolated distant recurrence, I want you to remember that. I have some slides here, what we showed. Isolated distant recurrence is a very, very rare event. You don't see that very often. Mostly it's combined with a local and distant failure. But keep that number in mind, less than 1% likelihood. And we and others have shown that there's a clear linear dose-response relationship. The higher the dose, the higher the overall survival. Neil Burnett has brought that to the max from Cambridge. He did the computer simulation, and he said, well, now we're at 60 gray total dose to the brain tumor and its edema, and you should go up to 200 gray to triple the overall survival. So that's the blue line here. That's his simulation. Neil is a radiation oncologist. He's basically in the RTC contouring, and he knows what he's talking about. He knows also that it's very provocative to say some sentences like, you use 200 gray in the brain, a patient will be dead. But the principle is that we just understand we need to have more dose concentrated on less tissue. It's where the action is. We don't need to treat the edema. We need to treat the cavity. It's exactly where the tumor recurs. And this is when, some 6 years ago, we said, basically the intrabeam has all of the characteristics we want to have for this procedure. We want to have a low range penetration. We want to have x-rays that simply sterilize 5 millimeters. and less around the cavity. And we have these various applicators. I came from Heidelberg. I was in oncology at that time, and I believed that there was never going to be a place in local therapy unless in brain tumors. So I immediately jumped on that and said that is a topic we should test. And then we came in the neurosurgical rooms, and when they see a radiation oncologist, you see the sweat pearls because you're a hazard to the patient and to anyone you're moving in sterile. Your movements are simply scary because you don't know. And so we came there, and the breast surgeons were familiar with us. They put us in the corner, and then comes the shield, and then the radiation oncologist. But the neurosurgeon, actually, we needed to look in the cavity. We need to estimate the distance to risk organs. We needed to be on the patient, and that's where the sweat pearls came from. And if you think about opening the brain, which is called craniotomy, smarter words, you the whole, you simply have no issue with having a suture or having to adapt something. You just take an applicator that fits snugly in the cavity. You try to make it a bit sort of a compression because there's always fluids leaking. And if you think, I was here 2 years ago, 1 year ago, and I said it's a very easy procedure. And everybody was like, well, in the brain. And then somebody shouted when I showed a video, that's not rocket science. And I hope you're believing me, that's not rocket science. So that's a brain here, right? Okay. And in it is. So that's in the cavity. Now, whether it's a metastasis or a glioblastoma, it's always the same. The round thing has to go in the round thing. Very simple. Okay, we can skip that. So the next thing was to put that at a more serious level. We do a phase 1/2 trial because we have no idea. There's some data from Northwestern, from John Karapuraka, who did that in children with the mild toxicity. But that was ependymoma and sort of recurring tumors. It wasn't glioblastoma, so we're the first to do that with glioblastoma. There's some very weak data with seeds where they did that weeks after surgery. They implanted seeds based on a 2-dimensional X-ray scan. So you can imagine where the seeds were going, anywhere but not in the tumor. So the issue was we needed phase 1/2 data, and unless this was looking quite favorable, we didn't go further. So we designed a very small single-arm 3+3 dose escalation. Like in pharma, you have a new substance, you escalate in steps of 3 patients. And we, in about 2015, we closed the trial with 15 patients. And here you see the first point, the first problem. 13 out of 15 were incompletely resected, so you had a post-operative tumor in the cavity. And every time we asked the neurosurgeon, do you think you got it out? And they would say, yes, 100%, everything's out. And then you do post-op scan and you see lots of tumor grouped around. I have some pictures for you. And many patients had non-resectable satellites. And then we live in a region where patients would come from Berlin, would get intraoperative radiotherapy, and then would leave back to Berlin and don't undergo per protocol therapy because they think that's enough. They got the shot. We told them that they're enrolled in the trial and there's a protocol, but there's 3 patients that would not stay in Mannheim. Also, were very beautiful, Heidelberg, and there's Frankfurt. No. So 12 out of 15 received per protocol therapy. And on top of that, some glioblastoma show a very unfavorable molecular profile. It's called methylated MGMT expression, a methylated MGMT promoter, and most of them had the unfavorable type, the unmethylated. Follow-up is 14 months, which is outstanding for a glioblastoma trial. It's because patients live that long. You see where it's heading, and we stopped the trial after 15 patients. Sum up of safety, we saw no dose-limiting toxicities. Most of the grade 3 events that occurred were not related to radiotherapy. You see 5 of them were related to radiotherapy. This is absolute standard, as you can see in all other trials that are not dealing with IRT. And there comes radionecrosis. This is elevated. 5 out of 15, 1/3 of our patients had radionecrosis. This is much higher than what you see in usual setting. But it turned out that you'd rather have a necrosis, be treated with bevacizumab for 2 weeks, and you're done with the necrosis, than having a recurrent tumor where you've been treated and you die. So 5 patients with radionecrosis, you have to make sure that you tell that to your patient. Occurred at any dose level, but we were fine with that since we have an active therapy for that. So, and here's the data that we also presented at SNO. We're very happy to have a large audience. They were very interested to hear that, and we just published a paper. You see that if you treat patients per protocol, and you look at the cavity and just a centimeter around the cavity, the median PFS for all patients is 14 months. That's double the time you've been expected them to be living before they have the progressive disease. And if you treat them per protocol, here on the right side here, you won't see a recurrent tumor. We didn't see a recurrent tumor in the first year, which was outstanding. It was really amazing because the data that's out, this is the Stupp data, this is basically the data. On this basis, we treat our patient every day. You see it's on the right column here, it's 7 months PFS. That's what we tell our patients. And we have now about 18 months in the trial. So you don't believe me probably unless you see some nice pictures. You see a temporal lobe glioblastoma here, patient number 2, nicely resected. Distant failure after 18 months. It's very rare to see a distant. It was just the second patient we treated and we didn't believe it. Died on a thing that the oncologist screwed up. It was not our point, 31 months. Patient number 5 here, unmethylated, both unmethylated. I have many pictures of unmethylated tumors, this with a negative prognostic factor. And here you see these white arrowheads, they're pointing to residual tumor after surgery. So in the early post-op scan, on the left side, it's a native scan, you see the blood. And on the right side, the contrast enhanced scan. So everything that's white in the native is blood, and everything that enhances then is tumor. You see, it's completely full of residual tumor. Patient is still alive, and after 16 months, you saw the radionecrosis occurring here. Treated him with Avastin, he's doing fine. He's still alive, by the way. And you see that the pattern of failure, which I would have liked to remember, it was 1% or less, is completely changing if you treat the cavity with a high-dose shot. So most of these patients that we then treated at higher levels showed a clear cavity. You see here, after 4 months, you don't see my cursor. That's the problem. Here, you see the cavity is clear. You see that homogeneous enhancing rim here. This is the death zone. It's homogeneously enhancing. Also here, it's a death zone. Although the cavity was strange and it occurred as if you would place an applicator and you don't get all the corners, but you will get it. If you look at the cavity, it's homogeneously irradiated. The death zone, so to say, is homogeneously irradiated. And all these patients then had later distant recurrence. Here you see what we're actually doing is we treat the cavity with some millimeters. If there's a satellite that's lying down about 1 centimeter or more, you don't get it with you don't catch this satellite. Here you see what happens then. This patient underwent a second surgery. The satellite will be growing because the radiation really just targets the narrow rim around the cavity. And you see strange things, and Ferran has already pointed it out, that in almost every trial on IRT and low energy IRT, there's somebody saying, oh, I have seen the same with abscopals. So this is a patient that we treated together with Roger Stupp from Switzerland. It's a patient that was operated in Mannheim and got the intraoperative shot, and then was having a second opinion in Roger Stupp's office, who's now at Northwestern, by the way. This patient got an IRT shot, and after surgery, you see probably better on the top page, you see there's residual tumor in the cavity. And that's really concerning. If you have that amount of residual tumors, probably grow back in 4 to 5 months. We gave the intraoperative shot, we gave radiochemo, we gave chemo, things we always do, and things happened. As expected, the satellite is growing and the cavity is stable. So that was sort of expected. And she then went to Stupp and he said, go get a gamma knife treatment for the satellite. And we didn't do it because she came in the office, we have a gamma knife, and I made a second MRI, and it looked like that. And I thought, I don't think that this is growing. Maybe we'll take another step and wait. And we waited and waited and waited, and then we waited more than a year, and the satellite disappeared. We have never seen that in glioblastoma. If you take a look at these images here, when she was admitted to the hospital, you already saw the satellite. You know this is tumor. This is not something like a radiation effect in the healthy brain. You know this is a satellite, and sort of this satellite disappeared over time. And based on basically these and other findings, we went in the laboratory, and for Iran we did almost the same. We looked a bit more in T-cell functionality, and did this with ELISpot. Here you see the ELISpot, and then if you take a look at the lower part of the graph, you see that the response basically measured with ELISpot, if you look at the T cells, if they are really going on the tumor or going against the tumor, is higher after IRT, although these numbers here we had to show this is very low, the number is very low. But that was the basis for a major grant we shot last year to go after that and to actually link IRT with immunology. We also were knocking on the doors of ZEISS for years then and told them that they have a very precious instrument, and there's about 20 companies, including Merck, Roche. They have been dying in the glioblastoma field, and they have been pulling out. And all the immuno trials now, they are expected with, they carry a huge hope of expectations. But we told them, if you want to run a new trial here, then you should simply implement IRT here in the standard of care, in the process of standard of care. And that's basically the trial that's now Intrago 2. It's a phase 3 trial. It's a bit complicated, but it's a trial where we simply add IRT to standard of care. We have some nice partners, some great partnerships established over the years. Most centers are in the United States. They're more open to participating than in Europe. In Europe, background probably, this procedure is reimbursed. You don't need to enter a trial. You can charge without being on a trial, and you have your benefit on the other book. So in Germany, we're getting 5K extra. In Switzerland, it's about 12K extra. Why then using a trial? You can just simply do it. And basically, we told ZEISS that the next thing we do is brain mets, and here Cleveland was the first center that actually started with it. We then implemented it and said, if it works and if there's no toxicity that's associated, no whatever, if it's manageable, we're going to implement it and offer that to our patients. Most of them are breast cancer patients, by the way, because sort of if you have that progressive disease, you're waiting for systemic therapies, and you don't want to wait another week for the radonc, and you don't want to wait another week to get your basically your radonc treatment. And we know that if you simply look at the yellow line here, if you simply do if you simply do nothing after surgery, 60% of patients will have a tumor recurrence. And there's 2 randomized trials that show that you don't have to boost the whole brain. You don't have to treat the whole brain or the partial brain. You just have to boost the cavity, and that's it, and then you're fine. The downside of that is the local recurrence rate at 1 year is not that good. It's 72% freedom of recurrence, so local control, if you just boost the cavity. And these are data from the randomized trials where they sort of did the operation and waited for a week and then boosted the cavity with a gamma knife or a linac or 2 weeks. And most of this, if you think that whole brains do not occur, I recommend to read that JCO paper. It's from 2017. It's not that old, where they looked at non-small cell lung cancers and brain tumors there. And I'm not going to go into detail, but there's 18% of patients that received surgery in whole brain. And there's 33% of all patients that underwent whole brain without the recommendation. I mean, the recommendation is to do surgery, boost the cavity, and then send the patient home. And in that paper, it was not a primary outcome of that trial, but it was sort of hidden in the table that there's many patients that received whole brain. Still, in the United States, 6 major centers that did NSCLC treatment. So looking at why we implemented, our patients are mostly waiting. They're after surgery, they're waiting for wound healing. Then they see me. They wait for me. I put them in the MRI, do another planning CT. Then best thing then can happen, they get a cavity boost. Any other thing is worse. Hyposparing is okay, but not indicated here. Whole brain is outdated. And then they wait again for oncology, and then they get systemic therapy. So since we implemented IRT, patients really come to us to get this one-stop shop. They're just waiting for wound healing, and then they're done. We can put them in oncology right away. We save about 4 weeks of time. And we prevent anyone to do a whole brain because we already treated the patient. So if this patient is going in somewhere in an outpatient setting, this is done. So Cleveland has done the first, I'm going to go over that for the sake of time. Cleveland has published the first set of patients, and you see here that most of these patients do not die of their brain tumors. They die from any systemic cause, and only 3 out of 19 died of CNS progression. Most of the Cleveland data set were pre-irradiated SRS, pre-irradiated tumors that grew back, that they would then take out and do the IRT there. And also there were some odd deaths. One died, one struck by a vehicle. We have a German site that's also participating in IntraGo. They have treated 17 patients, and this is their data after 1 year. It's approximately 78%, 80% freedom of disease here locally, and that compares very nicely with the SRS, with the randomized data. So they did this, they did the IRT shot, and they come up with the same numbers without the patient having to wait for oncology. The patient is treated right away on the day. So to sum that up, I hope I could tell you that I managed to convince Zeiss, so I hope I can convince you that IRT is something that's IRT with the low energy X-ray, something that's very suitable in the brain tumor setting. In glioblastoma, we saw a really manageable safety profile. We saw a local PFS as high as 18 months if you treat a patient per protocol. And you're going to see a shift in the pattern of failure. Patients will die of distant recurrence, which is, by the way, not my job. It's a job of chemotherapy. It's a job of the oncologist to develop new substances to keep them free from distant recurrence. But I do my job. The cavity is free. I showed you that we started the randomized phase 3 trial, which I would like you to encourage your radoncs and your neurosurgeons to take a look at that and maybe get back to us, and we're happy to include more sites. In brain meds, this is a home run. You treat the patient during surgery. Patient can be discharged and directly put in oncology. You prevent a lot of bad things, whole brains, and if you think it's not done, I recommend reading the paper on non-small cell. We think that the cavity boost after surgery is equal to cavity boost during surgery. At least the German guidelines and the German Society for Radiation Oncology has given us the approval that it's considered as standard of care. There's many sites in Johns Hopkins. We're getting rid of cesium implants, which they do during surgery, and implementing the intrabeam to just get rid of the of that sort of spillage of radioactive particles there. We have nice data from Cleveland, and we have good data from Augsburg. I think that's sufficient enough to offer that to our patients, at least in Germany. Yeah, and with that, I'd like to thank you again for your attention, for being open to something else than breast. And again, encourage your neurosurgeons, encourage your radoncs. It makes a lot of sense to use that in the brain. Thank you very much.